Hello, my name is Thor Halfdanarson. I'm a medical oncologist and the professor of oncology at Mayo Clinic at Rochester, Minnesota. I specialize in neuroendocrine tumors, and I'm pleased to be here to talk about the biomarkers. So let's dive into it. So, what is a biomarker? So, we'll go through a few or couple of definitions. So, a biomarker is a short for a biological marker, which is a measurable indicator of a biological condition or a process in your body. So, they can be molecules, they can be genes or proteins and physical characteristics, and they give us information on a bunch of different things, including normal biological processes. So, this would be like hormone levels, disease states, such as tumor markers for active cancers, and oftentimes these are blood markers. And then sometimes they can actually give us ideas about the responses to treatment. Let's say if a marker is getting better after a treatment was started, that might suggest that the treatment is working. And some of the newer markers might actually help us select the most effective treatment. So there are several different uses, and this is just one of those images that I wanted to show you. So we can measure a lot of stuff in the blood. We can measure hormones and DNA and RNA and even circulating tumor cells, but most of this we're not really using much for NETs. So we can use this for early diagnosis. We can use this to monitor treatment responses. We can use it possibly to detect the relapses early. And now, more recently, we might have ways of predicting responses to therapy, let's say with genetically directed therapy or targeted therapy. And we're starting to work on getting information on how to predict the risks of treatment. But that is really not in much use yet. So is there an ideal biomarker? Yeah, there is always an ideal biomarker. Do we have an ideal biomarker? No, we don't. So the biomarkers should reflect the behavior and the activity of the NET. So it should be abnormal when there is tumor. So that is called sensitivity. So the ability to correctly identify individuals who actually have a neuroendocrine tumor. And it should not be abnormal when there is no tumor. So that's called specificity. So the ability to identify individuals who don't have a neuroendocrine tumor. So it should be easy to do, and it should be widely available, and ideally it should have a fast turnaround time. It should be affordable and ideally covered by insurance plans. And most importantly, this should add value to patients' care. So it should improve outcomes for patients. It should help us guide treatment choices or avoid treatment where it's appropriate. And it should not be a source of harm, such as financial toxicity because of high costs, anxiety, or loss of quality of life. So do we have biomarkers that reduce the need for imaging? So we could think of such biomarkers where we would use them instead of imaging after surgery to monitor for tumor recurrence. So right now we're looking at the tumor grade and stage to predict recurrences, anatomically location of the primary neuroendocrine tumor, patient's age, comorbidities, and some people wish to be followed very carefully, others maybe not so much. So if we had an ideal tumor marker for this, it should be so reliable that we could skip the scans and just use the marker. We don't have a marker like that yet. And that's reflected by some of the guidelines from the major guideline bodies like NCCN and ESMO and NANET and COMNET. They don't use or don't recommend the use of tumor markers following surgery for surveillance. So we still are dependent on imaging. So I just wanted to bring this one up there. So this was in the New England Journal of Medicine. So it doesn't deal with neuroendocrine tumors alone, but it talks about routine surveillance for patients with cancer metastases. So patients with advanced cancer and or patients with localized cancer where we follow them over time to look for metastases. And really what they point out there that we don't have good information yet. That early detection using those fancy molecular markers helps patients live longer or better. So this still remains to be researched or studied better. And the authors of this paper just wanted to point it out that we are not quite there yet with markers and with all of the questions that we need to answer when it comes to surveillance after surgery. Good piece. Let's talk about some of the commonly used NET biomarkers, and I split them up in non-specific markers and specific markers. It's not the perfect way of thinking about it. So a non-specific marker would be something like chromogranin A. So that's probably the most commonly used one. And they just don't have the sensitivity and specificity that we need for monitoring after surgery. So they can be falsely elevated. And in some patients who have a tumor recurrence, they can be normal. So these markers are not recommended following surgery. So what about non-specific markers in patients with advanced or metastatic NETs? So to date, we don't have a marker that is perfectly reflecting the disease activity in patients with advanced NETs. And we don't have a marker that has been shown to improve outcomes. So we have really promising markers, and I'll show you some of them in a little bit, but we can't really rely on them only. So we still are very dependent on imaging. We know that patients with more advanced disease, they tend to have higher marker values, but where they do have more tumor. So that's certainly something that one would expect, the more tumor, higher markers. There was one study that looked at the chromogranin, which is a marker with a lot of challenges to interpret. But at least in this study, they found that if you have advanced neuroendocrine tumor and you have chromogranin measured over time, if the chromogranin is not going up, it probably means that the tumor is not growing. But the bottom line here is that the utility of nonspecific markers in patients with advanced NETs is limited. It's going to get better over time as we get better studies. What about 5-HT and serotonin? So we know that up to 50% of patients with metastatic small bowel NETs have carcinoid syndrome, so flushing and diarrhea. But we also know that flushing and diarrhea, especially diarrhea, can be from other causes. So we have to be able to tell the difference. Is this carcinoid syndrome diarrhea or is it not? And that's where we use markers that measure serotonin production by the tumor, whether that's the serotonin itself or 5-HT. So serotonin is a little challenging to do, so we prefer to do the 5-HIAA, which is what's called a metabolite or a breakdown product of serotonin. Easy to measure in blood and urine. We actually like measuring it in blood. It's much easier, has to be done fasting in the morning, and we prefer that over serotonin as a better marker. So elevated serotonin or 5-HT in patients with NETs and with diarrhea and flushing is really strongly supportive of carcinoid syndrome. But here is the thing that we need to remember is that you can have substantially elevated serotonin and serotonin production and 5-HT, but no symptoms. And you might be at risk of developing some of the complications of serotonin production. So what would those complications be? One of them would be carcinoid heart disease. And then just what we call subclinical carcinoid syndrome. So you might have carcinoid syndrome without sort of the typical severe diarrhea. And then knowing the serotonin levels or the 5-HT helps us determine if your diarrhea is from carcinoid syndrome or not. So let's say if you have a metastatic neuroendocrine tumor and you have diarrhea and the 5-HT is completely normal, then it's probably not syndrome diarrhea. But you have to think of these other diarrheas, the bile acid diarrhea, and we have better tests like 7-ACE4 and the bile acids in stool to look for that, and exocrine insufficiency. So this is what we see with octreotide and lanreotide, sort of impairment of the ability to digest fat and other nutrients. So serotonin is the critical component causing the carcinoid heart disease. So we need to know that as well. And patients with normal serotonin or normal 5-HT should not have carcinoid heart disease. And if you have metastatic neuroendocrine tumor and elevated serotonin production or 5-HIA, and even in the absence of diarrhea and flushing, you can still get carcinoid heart disease. We've seen that over and over again. Substantial serotonin production, no diarrhea, and if we hadn't looked for the serotonin or the 5-HT, we would not have discovered that. So what about other functional neuroendocrine tumors? So a functional neuroendocrine tumor that can produce symptoms, and the symptoms do result in a syndrome, so a functional syndrome. So we can monitor such functional markers over time, and I'm just going to give you a few examples of those. Those are mostly pancreatic NETs, although lung neuroendocrine tumors can do this too. So this would be like insulinoma, where the tumors are producing excessive amounts of insulin, causing low blood sugars, gastrinoma, causing Zollinger-Ozar syndrome, which is severe gastroesophageal reflux, stomach ulcers, and diarrhea. And then the really uncommon neuroendocrine tumors like VIPomas, the production of a hormone called VIP, or vasoactive intestinal peptide, which can cause severe diarrhea. And then even less common would be the glucagonoma that causes the glucagonoma syndrome, which is diarrhea, diabetes, weight loss, and some patients get this really characteristic skin rash. And then we have those other like really rare functional tumors, or OMAs, as I call them, the PTH or Pioma, somatosatinomas, even serotonin, which we didn't think was produced by pancreatic neuroendocrine tumors, can actually be produced by them. So what about the novel NET biomarkers? Everyone wants to know about those. So let's talk about the NET test. So a NET test is an interesting test. So it's a blood test that evaluates 51 NET or neuroendocrine tumor-related genes. And the results are reported as a NET test score, which indicates the likelihood of NET being or neuroendocrine tumor being present, and the progression score, which suggests that if you have a NET, how likely is it to progress or grow in the future? And it's been compared to chromogranin multiple times, and typically beats chromogranin in terms of how sensitive it is. But that's admittedly a low bar. So chromogranin not being the greatest test, it's kind of easy to beat that. So the problem is that the added value of the NET test is unclear. So number one, it has not been shown to result in cost savings or to improve outcomes. That is, if I use a NET test, I'm not sure if my patients will do better over time. And then a lot of patients will have detectable or positive NET test or a fluctuating NET test, but no detectable NET. It's possible that they may have an NET, a small NET that over time will show up, but there's no evidence to suggest that detecting that early with a blood test when nothing is visible on scans improves outcomes. So it's promising. It outperforms some of the other markers. The added value in the clinic is not yet proven, but we just need more data. And then we see a lot of positive results despite negative scans, and we just don't know what to do with it. And that can cause a lot of anxiety. So what about circulating tumor DNA? So we can do that with two sort of purposes, if you will. So looking for a target, and let's say someone has mutations, and we're looking to for a mutation we can target with some of our newer drugs. This is attractive, but as most well-differentiated NETs don't have a lot of mutations, and these mutations are very rarely targetable, it's not very helpful. But we're fairly early on in this, so keep an eye on these tests. I think these tests will get better. Our understanding of the mutations of NETs will get better, so we'll probably see more of this. The other one is what's called tumor-informed ctDNA, or circulating tumor DNA. So this is like Signatera. These are tests that we use to detect recurrence, and they appear to be promising in other cancer types like colon cancer, but we just don't have the data for NETs yet. And I'm a little worried that this is not going to work for neuroendocrine tumors because they don't have a whole lot of mutations. So, but we just need more information. We need more research studies. Well, what about testing tumor tissue? So genetic testing is used in oncology all the time now, mostly to identify potential targets for therapy. And mostly, at least in the neuroendocrine world, seems to be mostly limited to poorly differentiated neuroendocrine carcinomas. But there must be enough tissue for testing, and sometimes we just don't have enough tissue. A tiny little biopsy, we have to biopsy again, which is no fun. And there are multiple different providers, and I'm just throwing out a few names there: Tempus, Caris, Foundation Medicine, Exact Sciences, and many other excellent labs that do this. The role for well-differentiated NETs is still small, but this, I think, will only grow over time as we get more information, as we learn more about these tumors. So what about other tests, which we can consider biomarkers? So germline testing to look for inherited conditions such as MEN1, VHL. So, but most NETs are not hereditary, and it's been studied in high-grade neuroendocrine tumors and in other neuroendocrine tumors. And the most patients will have negative tests, but as our tests get better, I think we're going to pick up more positivity, and we just need to better understand what to do with those results. So we're starting to get the tests that look at the efficacy or predict efficacy of therapy. One of them would be something called PPQ, or PRRT predicted quotient. It's a relative of the NET test that might predict the efficacy of PRRT. pretty early on still, but something we might be looking at in the future. We can look at some other tissue-based tests, such as mutations in genes called ATRX and DAX, and something called ALT in pancreatic NETs. Still fairly early on, but might be entering a routine practice. And then we're just starting to look at predictors of risks and toxicity. And there's something called CHIP, or clonal hematopoiesis of indeterminate potential, which might possibly predict the risks for like low blood counts and possibly leukemia following PRRT. Okay, so to wrap this all up, I think clinicians should familiarize themselves with the most up-to-date and most recent guidelines. And I want to put this out there. So this is a combined effort of COMNET, which is the Canadian and Australian and the New Zealand NET organizations, with NANETS, or the North American Neuroendocrine Tumor Society. These guidelines were just published late in 2024. They are absolutely excellent. And actually, they do have in the appendix some really good patient-focused stuff in language that's very easy to understand. So this is open to the public, and they encourage practitioners and patients to take a look at this. So if you're going to order a biomarker, I think you should ask yourself these questions. So will this help my patient? And if I order this test, do I have the knowledge to interpret the results and explain them to my patients? And how will this alter the management of my patients? Will it do anything different, or did it just add cost and anxiety? And then make sure that these tests do not result in financial toxicity, that they're covered by insurance plans before you order them. And if there is a co-payment, is there or some sort of like an assistance program that will help with some of those costs? And how do I deal with the potential adverse effects of ordering the test? What if the test comes back positive and there's nothing on the scans? How are we going to deal with the anxiety resulting from that? So the bottom line, net tumor markers should bring value to patient care, and I think that's where we need better information. Most of them don't really bring a whole lot of value, but if you use them carefully, they can be helpful. But they're just an additional data point. On their own, they don't really do much. So treatment decisions should rarely, if ever, be made on marker results alone. And we should therefore use markers selectively. So that brings us to the end of my presentation. Thank you very much.